monitoring so that, and we now have remote monitoring, which allows us to monitor the device at a higher frequency than coming in once every 3 months. And it is important, if at all possible, for you to have remote monitoring because it identifies problems uh, much more rapidly than coming in. So the actual annual shock rates have declined. Now, what are the chances of being shocked? Now, this depends on your condition, but I'm going to throw a number out there just for sassy's sake. 4 to 6% annually. Now, that doesn't help David, who's gotten 4 this year, okay? But the goal of medical care and the goal of optimal medical treatment is for you never to get shocked. That's why they're going to go in and do an ablation on David. That's why he's on so many medicines, because what we're trying to do is suppress the chances, suppress the conditions by which arrhythmias emerge and therefore need shocks. So annual shock rates are quite a bit down. When I first started working with defibrillator patients, they were in the 40 to 50% range annually. So 1 out of every 2 patients would get shocked. Today, 4 to 6%. The most common period of being shocked is from the first months or 2 of the device because the thing's getting put together and we're getting medicines and stabilizing the condition. I mentioned these rates before of depression, PTSD, and anxiety. This time I want to show you just these, though, that one of the reasons we have such high rates of shock anxiety is because many people believe that they're going to get shocked every day. Well, of course, so that's not true. The rates of shock are so much lower. We know that people avoid activity at very high rates as a way of somehow preventing shocks, which won't work. And we know that most people don't really understand their device. They don't quite understand why it's there, how it works. And we know that the groups of patients who are most likely to have psychological distress are those at age 50 or lower. Okay, but that's obviously a soft number. Women are more likely to report distress, shocks, premorbid psychological problems, feeling alone, not understanding your condition, and more severe comorbidities, conditions that are harder to manage. And then over on the side that seems to help is optimism and social support and faith in ICD and doctor, right? So that's why it's so important that invalidation doesn't happen like what happened to David, is that, he loses faith in both his doctor and the ICD if people say, get out of here, you're just lucky to be alive. I mean, what a silly thing to say to somebody, right? It doesn't reflect the experience of the threat that they just experienced. And when you look at research into what ICD patients feel like they need help with, this synthesized all 24 papers recently, and fear and insecurity was the most common need. Patients needed support or needed some help around feeling fearful and insecure. So it's no secret that that's why I spent so much time on that earlier. You can see the other key ideas here, living with shocks, how life is interfered with. All right. So I've only gotten through, I think, 4 of my things you need to know. Let me hit these last ones so I can be done with these slides. Engage, avoid avoidance. So we know that what do you love to do is really important. Life's full of activities of fun, intimacy, awe, peace, things that matter. The Cascades in Central Washington are a must-see, David, right? You've already been out there. They're a must-see. I've never been in. I've been to some beautiful places, but they're in the top couple. That's all of us live somewhere that something should stop us in our tracks. I went out and looked at big ass trees out in California a month or 2 ago. I mean, I didn't think I'd really like seeing trees, but they were amazing, right? I'm just tiny compared to these trees. Activities that bring you peace, finding times in which you do find peace. Activities of fun at Shark Week, man. That's fun, right? As long as I don't have to be out there with them, it's fun to watch them. And certainly intimacy means being close to somebody that you love and being able to get back to those. One of the concerns we have as psychologists is this right here called experiential avoidance. And specifically what this means is all of us have situations we need to be in. And there's certain kinds of things that we have to do. And things we have to do bring thoughts and feelings and physical sensations like, oh, I have to give this speech. Maybe they won't like me. Maybe they will wish I had hair. Maybe they will wish I was nicer or funnier or something. And you have to push through that to have some experience. If I do that, then I become calmer and I actually am able to be more flexible and stop and ask for questions and not be so anxious. But if I just said, I'm going to talk really fast and not give you a chance to talk, and that way I'll avoid it, and then you'll never have a chance to show that maybe I don't know anything. I mean, what kind of dummy doesn't learn anything after all these years? And so experiential avoidance versus experiential acceptance becomes so important. And it's exactly here that we focus our work. My clinical work is focused on these three things. Those of you, like I think it was Heather who said she's looking for someone to help her. These are the three elements you need help with. When things happen to our heart, we tend to catastrophize and say, this is awful and I can't get through it. We tend to avoid and say, I'm not going out. I am not going to exert myself, and I am going to walk on eggshells. And the last thing they do is, I'm going to watch my heart. I'm going to catch it before a problem happens. That way I won't get shocked, none of which will work. But nonetheless, these are the natural, every single person tries to do this. You can't not. Smart people try to predict things, prevent things, and think things. You can't not do that. Now, the point is not so much that you have to accept that. It's you got to experience it. You got to come back to experiential acceptance. You got to say, okay, yeah, you're right. I freak out sometimes. I scream. Okay. Okay, sometimes I should go out and I stay home. But I really need to be out because as much as it's nice to stay home, rewarding things happen when we go out and do things for other people, namely, and with other people. Doing nice things for other people is actually better for the person who does it than who received it. Mm-hmm. So reminding yourself, how do you defeat these? I'm safe and strong. I got a device. I got one of the top 50 inventions in the world. I'm going to survive. There's nothing these people can throw at me. God dang it, I'm coming at them. That's sometimes I drop an F-bomb in there. I held back. But, I'm coming at them. I'm not giving up. I love my life, man. The people in my life are worth getting anxious about sometimes. Anyway, I think the idea here is that finding a way to re-engage anyway. I'm getting back in the swing of things, come hell or high water. And deliberate actions, looking for small ways that you're going to make positive things happen. There's a lot of theories in psychology about getting people out. And when we get people out, they're more likely to actually run into positive things. I know that's hard to believe when you watch the news. You think everybody's evil everywhere. No, they're not. The vast majority of people are actually incredibly kind in real life. Maybe not so much on cable news shows, but they certainly are in real life. Finally, the ICD is implanted in the family. Nobody does this alone. This is a disease that we're often dealing with that is complex. It affects everybody. There's nobody who gets untouched. This is not a spectator sport. Everybody's involved. Everybody's on the team, whether you like it or not. Even if you don't want to be, you're drafted. Sorry. Issue them jerseys, man, because you're on the team. You don't get to choose. And when you look at loneliness, this idea of loneliness is just a silly study I threw in because I just wanted to highlight that even the Surgeon General this year came out and showed that loneliness is approaching the level of toxicity of estimated glomerular filtration rate, which is basically kidney disease. Now, it's not as bad as albumin to creatinine ratio, again, another kidney marker. That's the protein in your blood. And then you have BMI and high cholesterol. Yeah, these things are associated with bad cardiovascular disease. But look at loneliness. Look at depression. Still, these are problems. And, we don't have to necessarily tattoo each other, but I think it means that you're in this thing together. And the data says that actually is true. In fact, the University of Washington's group of researchers that I work with there, the nursing group actually, showed that in 301 patients were randomized to sort of coaching. And in patients who brought their spouses or partners versus those who went alone, they were randomly assigned to either you're allowed to bring somebody or not bring somebody. Those that brought somebody were much better off overall. The patient and partner were more likely to benefit and have less symptoms, less depression. And the partners benefited somewhat, but you'll note down here, partner anxiety and depression were stable across 12 months, meaning that despite the coaching intervention, spouses actually kept on worrying. So it might mean that we have to do a little bit more with spouses. Somebody mentioned environment earlier. I think it was Cindy who was talking about environmental. Well, having a, anxious spouse all day will drive you nuts. Being overprotected is crazy, right? We're grown. You're grown. I'll tell you who does do this. Your ICD. Your ICD is already doing that. You're not even good at what you're trying to do. You're not good at figuring out arrhythmias. You don't know they're coming. Let the device do its job. Now, I'm going to end with just a quick story about Christopher Eriksen. I think many of you may know this story. Christopher Eriksen is a world-class soccer player in Denmark. He had a cardiac arrest during a Euro Cup match. I don't watch soccer much, but this is Christian Eriksen. He was at the top of his game. He's a world-class player. Christian Eriksen, in fact, has gotten a defibrillator and has returned, played in the World Cup, plays for a premier team in Europe. I like a couple things that he says, and I will stop at that. My ICD is here for my protection, right? Safety net. It's in me because if anything would happen to me, there's no need for a defibrillator because I will have my own. It is really just extra security. I'm more protected here than you guys. A little swagger is what that is, right? I like that. And that's how I feel. I feel protected. I feel normal. That's what I'm talking about. Oh, it's all a happy-go-lucky now. You got a defibrillator. Everybody goes, let's cheer. Hey! May 10th. Christian Eriksen reveals he watched footage of his collapse at Euro 2020 the next day while recovering. And as the Manchester Star admits, it never gets any easier 2 years after my cardiac arrest. But I also have been around a long time. I've taken care of more ICU patients and more sudden death patients than anybody in the world as a psychologist. I believe this. They whispered to her, "You can't withstand the storm." She said, "I am the freaking storm." So my 5 things I wish everybody knew: no one trusts your ICD. You don't cause shocks. You probably overestimate your chances of shock. Avoid avoidance. And ICDs are in families. Thanks very much.
Thank you.
So I'm happy for questions or comments at this point. I can see about 10 of you. So
Hi, can you hear me? Oh.
I can see you. Is it Anna Lucia?
Oh yeah, you said it perfectly. That's
Where
odd.
are you calling in from tonight?
Brooklyn, New York.
Brooklyn, New York. All right, good.
Yes, yes. I'm not having any issues with like the anxiety or anything. I'm more with, I forgot her name, the first woman who talked. I'm more at
Heather.
like an angry kind of like, why me? Because when mine happened, which was just January 31st, it was like, it started with something they said is very kind of rare. It's called spontaneous cardiac artery dissection.
SCAD.
And then
SCAD.
Yes, a lot of people have not heard of that. I never heard of it. And then within minutes, it went from like that. And then I had a heart attack. And then I went into sudden cardiac arrest.
Yes.
And they had to do like the paddles. And
Yes.
it was just like a very normal day. I was at work.
Yes.
And from what most doctors in the emergency room told me when they got me there, that was like the luckiest day of my life, like how
Yes.
everything just aligned.
Yes.
So I'm at the whole like how everything has changed. Like now I'm 52. I have a cardiologist. I have to check everything with them. I got to do cardiac rehab. And I'm like, I'm 52 years old and healthy. Like, how did this happen?
Yeah. And and SCAD will also give you very little insight, right? I mean, most of my
they don't
comments
really
tonight,
have it.
right. And most of my
Yeah.
comments tonight had to do with arrhythmias, right? And while you did experience arrhythmias, the cause is a known, you have a vascular cause, right? So we actually understand what happened to you. The reason they say that luckiest day stuff is because it's a highly lethal condition in the field.
Yeah.
Very, very dangerous condition in the field. It is, the odds are against you when that happens out in the field.
Yeah.
Now, the other thing about SCAD is you won't see a lot of support for SCAD. SCAD is such a rare condition. It does tend to
Hmm.
happen in women at higher rates. It
Yeah.
does. Do you know what hospital repaired your condition?
Oh, NYU. That's my
Okay.
hospital where all my doctor is also.
So Langone or
Yeah.
NYU? Okay,
Langone.
NYU. Okay. So, um, so Langone's a very sophisticated center, right? I mean, this is one
Yeah.
of the medical centers in the world. Um,
Hmm.
so the cardiac surgeons that repair these, um, we actually don't have a lot of research about how to help you recover psychologically. There are only a couple of studies look at that. Now, what we have to do then is understand, well, how different is a SCAD? I mean, it's very
Hmm.
different from a surgical repair, but from a recovery standpoint, trusting your heart again, trusting the
Right.
repair, following,
Hmm.
getting good scans, following up with you, getting a good relationship with the clinic, because you're going to sometimes
Yeah.
want to. You're going to need reassurance some days. That's just the way it is.
Hmm. Yeah.
You get struck by lightning, you look at the weather a little more. You know what I'm saying?
Right. Yeah, that's what it felt like in my chest that I got hit by lightning.
Yeah.
But there was no procedure. There's like no procedure for it. It kind of heals on its own.
Okay.
And their
So that's
protocol
good.
is to kind of treat it like as if I had the regular heart attack. Like they put me on blood pressure medication, a statin, aspirin, and I don't have high blood pressure or cholesterol issues, but it's kind of like the only protocol they know to do for it.
Yeah, and that's good. So your SCAD was not a complete rip. It was
No.
serious, but they didn't have to
Hmm.
surgically repair it. That's encouraging.
No.
And what we've learned is that optimal medical therapy, we're learning about how to manage the necrotizing process that actually is associated with the tear, how the tear happens. We're learning more
Hmm.
about that, and you may be surprised or whatever. But statins really appear to be one of the major ways to sort of make things smooth again, and maximal
Hmm.
medical therapy is quite effective.
Yeah.
So we can hurt you by going in and messing with it.
Yeah,
And
that's what they said. Like they used to do stents for it, but then they kind of geared away from that because it seemed to cause more damage than help.
yeah,
I
yeah,
don't know.
like open up your chest. Yeah. I
Yeah.
mean, and it wasn't clear that it was doing more to help you. They
Hmm.
stated they gave you a safe landing. And I
Yeah.
think that's really the key issue. But again, you still have to encounter, trusting, exerting yourself again in cardiac rehab, psychotherapy, working with
Right.
physical therapy. Those things are ways in which we have to help
Hmm.
you overcome, because anybody would be afraid of exerting after that. It's completely
Yeah.
reasonable.
Yeah. Because I wasn't even exerting. I was like at work. It
Yeah,
was weird.
which makes it even more like lightning, right? Because
Yeah.
like unexpected.
We have
Thank
a
you,
Hmm.
David. I know you have your hand up. David.
Hey, Dr. Sears, thanks for the talk today. I'm 38. I got my ICD about 15 months ago, and I feel incredibly lucky to have this piece of technology inside my chest, right? So I don't really have too much anxiety when it comes to that. My question is, I never really want to use it, right? I'm wondering
Yes.
how often do people go? Because I have a long way to go, hopefully. How long? What are the odds that this thing never goes off?
Well, every year you maintain, as long as the condition remains the same. So you didn't tell me your diagnosis. You don't need to. But the point is this: the condition by which you demonstrated you needed an ICD, as long as that persists, you're in a 4 to 6% range every year.
Okay, so it's dilated cardiomyopathy. So I'm not sure if that changes anything.
No, because dilated cardiomyopathy just refers to what they actually see there, right? So the actual anatomy is dilated. That doesn't actually tell me the cause. For the purpose of this, I don't
Got
need
Yeah,
the cause.
for sure.
But the point is that as long as there is a change in the anatomy of your heart, the geometry, if the structure is dilated, and so therefore you have what's called cardiac remodeling, as long as that's occurring, then there's a degree of risk. Now, if we can get you back into a normal size, shape, function heart, then the odds change again. But let's just say for the best we can tell, we'd be looking at a 4 to 6%. Now, if you've had a frank cardiac arrest, it starts moving closer to the 8s, 9s, and 10s. But again, these are very squishy numbers based on which trial you point out, which condition you have, how the device is programmed. So there's no way to give you a single number, but you're still not. So you could go at that. I mean, statistically you could go a while and not get shocked if the rates are 10% per year for your condition, let's say.
Yeah.
I mean, statistically, of course, you could go and not get shocked. My point to you psychologically is do not allow yourself to be ambushed. See, because there are some cardiologists who say, tell them they're never going to get shocked. I mean, come on, it's a low chance. And I say, there's a low chance. But let me tell you, the most difficult, angry patient is the one that got ambushed.
That's right.
Okay. So my approach, and it has pros and cons. I could, give you ignorance. I don't believe ignorance works in this situation. I think that's a silly tactic. I think being aware, I think you're grown. I think everybody's grown. I think they can deal with risk. I think if you tell people they can't handle it, then they learn not to handle it. I think people handle things. I have great faith in people. I sound like a politician. I have great faith in the American, but I do have great faith in people. And so I think I understand your question. And my only point is, yeah, I hope that you never get shocked. And the goal of all medical care and all teams is so that you never, ever use this device. It's there as a safety net. We don't want you to use it. But if you do, then we need to own up to it, help you get over it, recognize why it was there, recognize what happened, be grown up, deal with it. Because that's the way it is. And I think we can do that respectfully. I think we can do that because I believe patients are tough. I think they can handle.
I appreciate that.
I'm on a rant again. Sorry, man. Sorry, David.
Hey, thanks, Doc.
I hate seeing people stressed out over things that I think we can help them with. Hi, Kathy.
Hi, how are you? Thank
Great.
you for your talk. I'm much like Heather, where I had my cardiac arrest 5 years ago. I have an ICD put in. My doctors could not find any reason why this happened to me. They did the cardiac MRI like 3 days after my cardiac arrest. I was only down for probably maybe 10 minutes or so. I woke up, yelled, "Get the hell off me," after they had shocked my heart like 4 times. They did the cardiac MRI. They asked me if they could use my MRI as a teaching tool because it was completely normal.
Clean.
So like they put my ICD in. Now my electrophysiologist wanted to do all these tests to find out, the name of it, because he figured it was a rare genetic condition that I had that caused my heart to misfire. Mm-hmm. And I was, after all the testing, I said to my other cardiologist, well, what's going to change? She said, you're going to have a name. I'm like, I don't need a name. The doctor wanted to come up with a name to be like, oh, he discovered some kind of rare condition. And I was like, no, I don't need a name. If the pacemaker defibrillator is in there and, I don't need a name. I'm fine with rare genetic condition. And, I've gone 5 years. In fact, when I had my device checked in January, the girl was like, did I miss something? And the person from the Boston Scientific was there and he said, no, you didn't miss anything. She's not using hers. She doesn't need it. Like, I'm not that I don't need it. It is that security. I feel like that soccer player. It makes me feel normal. It's my safety net. But yeah, that fear or that anxiety about the cardiac arrest doesn't go away. Things bring up, that anxiety. But every day, when you said like people, how, like, do you fear it's going off? I don't even think about it going off.
Yeah. And
I'm lucky. I feel bad for people like David, who it has gone off. Mine has never gone off. It hasn't. It is only. They told me it's only paced my heart in 5 years, less than 1%.
Yeah, I mean, you have a true safety net in there. It's just like it's the safety net set up. Probably never use it. Hope you don't. But like I was telling David, okay, but don't sleep on it either. From the standpoint of, well, if something happens, you know what to do. You're going to call the doctor. You're going to let them know what's happened. You can remote monitor. You can go to the ER. You
Right.
got right.
Well, I
I
think-
don't have any concerns about what you said. I think that that's absolutely fine. I guess a different way to say this is, for some people, the curiosity of cause is as important as consequence. For you, you don't care cause. You're already about the consequence. You're already. So do you want to know what
Right.
happened before? Some people do. Some people don't. Do you want to know what's going on now? Yeah. So
Yeah, I did
okay with it.
initially want to know, but after like it went on and they had to do testing that could have possibly caused damage to my heart when I didn't have damage, I was like, no, I don't need to do that just to find a name. And on David's note, David, what you could say to some of those doctors who say, oh, your thing is just, until they have suffered cardiac arrest, until they have got shocked, they have no right to tell you how you feel.
Right. I think we have to wrap it up soon, Dr. Sears. And I know Corey had a question before. Corey, did you still have a question? Okay. Yes, not. Okay. Well, thank you, Dr. Sears, so much. We're just so honored that you were able to spend time with us today. It was an excellent talk. And thank you for everyone who came here today. It was really great turnout, and we appreciate your participation in CASA. So thank you very much, and enjoy the rest of the day.